Welcome back to the channel. I'm Renee Sorbonne and we are in the middle of our Acne Awareness Month series. Today we are going to look at one of the most frustrating scenarios in the treatment room. The acne client who simply is not getting better. They have the papules, they have the pustules, they have the redness, and you have adjusted their home care and supported their barrier, removed the obvious irritants, and yet the condition persists or even gets worse. When that happens, we need to pause and ask a very important clinical question. Is this actually acne? Because not every acne-like presentation is acne vulgaris. And when we treat the acne mimicker like acne, we can make the condition significantly worse. As estheticians, our scope of practice is to analyze, not diagnose, and that distinction matters. We are not diagnosing medical conditions, and we are not replacing the role of physicians, dermatologists, or prescribing professionals. But we absolutely need to recognize the patterns. We need to understand when a presentation does not behave like acne vulgaris, and we need to know when to adjust our approach, stop pushing the acne actives, and recommend medical referral when necessary. This is where the clinical analysis becomes so important. We are observing, we are assessing, we are connecting the client's visual presentation, their history, their symptoms, their triggers, and response to previous treatments. And when the pattern does not make any sense, we need to stop treating harder and start reassessing smarter. Today we are going to look at 3 common acne mimickers, and these are conditions that can look like acne at first glance, especially to the untrained eye, but they have different underlying mechanisms. They do require different management, and in many cases, if you treat them with standard acne protocols like aggressive acids, benzoyl peroxide, drying treatments, harsh exfoliation, and so forth, you can actually create a flare instead of improvement. The 3 presentations we are going to look like in this video is perioral dermatitis, Papulopustular Rosacea, and Malassezia Folliculitis, which is often incorrectly referred to as fungal acne. Now let's start with perioral dermatitis, or more accurately, periorificial dermatitis. Perioral dermatitis often presents with a cluster of small red papules and pustules around the mouth, chin, and sometimes even the nasolabial folds. At first glance, it can look very much like hormonal acne breakouts, but there are important differentiators. The one key clue is that it often spares the immediate lip border. You may see irritation around the mouth, but there is often a clear ring of normal skin directly next to the lips. Surrounding skin might feel dry, sensitive, tight, scaly, or even reactive, and the client may describe burning or itching rather than the deeper tenderness that we often associate with acne cysts. Another important history question is topical steroid use. Perioral dermatitis is commonly associated with corticosteroid exposure, including creams that may have been used for a minor rash or irritation. The skin may appear to improve temporarily, but then rebound when the steroid is stopped. This is why strong active acne can be such a problem here. If you treat perioral dermatitis like acne, you may trigger a significant flare. In this presentation, the barrier is already highly reactive, and the safest aesthetic approach is often to remove irritants, simplify the routine, support the barrier, and refer when medical management is actually needed. The second acne mimicker is Papulopustular Rosacea. This is one of the most common sources of confusion, especially in adult clients. A client may present with red bumps, pustules, inflammation, and facial redness. To the client, and sometimes even to the practitioner, it looks like adult acne, but the clinical pattern is different. Rosacea has vascular and inflammatory components associated to it, and it often involves the central face redness, visible blood vessels, flushing, and sensitivity, And the key differentiator is that you do not see comedones. With Papulopustular Rosacea, you may see that central face erythema, you may see the papules and pustules, but you should be looking very carefully for the absence of those comedones. In acne vulgaris, we expect to see open or closed comedones because acne involves obstruction within the pilosebaceous unit. Blackheads and whiteheads are part of the acne picture, and with rosacea, you may see inflammatory lesions, but not the same comedonal pattern. You may also notice that there is a history of flushing. The client may react to heat, spicy food, alcohol, stress, intense exercise, or temperature changes. That history matters in this case because if this is rosacea and we treat it like acne instead, with harsh exfoliations, benzoyl peroxides, drying treatments, aggressive peels, and so forth, we can aggravate the neurogenic inflammation and barrier dysfunction. The clinical focus should shift towards calming, cooling, barrier support, even trigger awareness and referral when the presentation is outside our aesthetic scope. Okay, the third mimicker is Malassezia Folliculitis. You may hear people call this fungal acne, but that term is not accurate as it is not acne. It is a folliculitis associated with an overgrowth of Malassezia yeast, and it behaves very differently from acne vulgaris. This is where treatment history becomes extremely important because if the client has been using antibacterial acne treatments and nothing is changing or it is getting worse, we really need to reconsider the original analysis. Malassezia folliculitis often presents as very uniform monomorphic papules and pustules. That word matters, monomorphic. The lesions often look very similar to one another. They may appear on the forehead, the jawline, the chest, back, or other sebaceous areas, and the client often describes itching. That itching symptom can be a very helpful clue because acne vulgaris is not usually intensely itchy in the same way. Now, the underlying driver is also very different. Acne vulgaris is associated, among other things, with the Cutibacterium acnes and the follicular environment, whereas Malassezia folliculitis associated with yeast overgrowth instead. So antibacterial acne treatments will not solve the problem, and in fact, antibiotics may sometimes worsen the balance by reducing competing bacteria and allowing the yeast to thrive instead. This is why the slide says antibacterial acne treatments will fail. The key takeaway is not that we diagnose it ourselves. The key takeaway is that when the pattern is uniform, itchy, resistant to acne care, and located in typical follicular areas, we should reassess and refer appropriately as necessary. So this is why clinical analysis is the foundation of our practice. We cannot rely on a visual snapshot. We need to connect the dots. Where are the lesions located? Are they comedones? Is there flushing? Is there itching? Is the immediate lip border spared? Is there a steroid history? Has the client used antibiotics? What has made this better? What has made it worse? And more importantly, does this presentation that we're seeing on the client's skin today actually behave like acne vulgaris? When the treatment fails, you must reevaluate your initial analysis. Not every breakout needs stronger acne treatments. Sometimes the best clinical decision is to stop, simplify, support the barrier, and refer. Now, this is exactly why assessment skills matter so much. Protocols are helpful, but they are not enough. The skin does not always follow the category that we assign it to, and as practitioners, we need the confidence to recognize when something falls outside the standard acne pathway. Inside my Professional Skin Assessment Mastery program, this is the clinical reasoning that we develop. We look beyond the surface, we assess the patterns, we evaluate the history, the symptoms, the triggers, the barrier condition, and the treatment response, and we build the confidence to know when to proceed, to know when to modify, and also to know when to refer. Thank you guys so much for watching. Please like, subscribe, and share with your fellow practitioners who wants to get better at analyzing acne-like presentations. I will see you next week.